Hello and welcome to the Coding Corner, Medical Coding Education. Today we will be covering chapters 16, 17, 18, and 19 of the ICD-10 CM chapter-specific coding guidelines. My name is Kristen Robinson. I am a coder, auditor, and educator, and let's get into it. First up, we have Chapter 16. This is for certain conditions originating in the perinatal period, and this is for codes P00 through P96. We have a few general perinatal rules that we should cover first. Number one, use of Chapter 16 codes. Codes in this chapter are never for use on the maternal record. Codes from Chapter 15, the obstetric chapter, are never permitted on the newborn record. Chapter 16 codes may be used throughout the life of the patient if the condition is still present. Number two, principal diagnosis for birth record. When coding the birth episode in a newborn record, assign a code from category Z38 for live-born infants according to the place of birth and type of delivery as the principal diagnosis. A code from category Z38 is assigned only once to a newborn at the time of birth. If a newborn is transferred to another institution, a code from category Z38 should not be used at the receiving hospital. A code from category Z38 is used only on the newborn record and not on the mother's record. Number three, use of codes from other chapters with codes from Chapter 16. Codes from other chapters may be used with codes from Chapter 16 if the codes from the other chapters provide more specific detail. Codes for signs and symptoms may be assigned when a definitive diagnosis has not been established. If the reason for the encounter is a perinatal condition, the code from Chapter 16 should be sequenced first. Number four, use of Chapter 16 codes after the perinatal period. Should a condition originate in the perinatal period and continue through the life of the patient, the perinatal code should continue to be used regardless of the patient's age. Number five, birth process or community acquired conditions. If a newborn has a condition that may either be due to the birth process or community acquired and the documentation does not indicate which it is, the default is due to the birth process and the code from Chapter 16 should be used. If the condition is community acquired, a code from Chapter 16 should not be assigned. For additional information for COVID-19 infection in a newborn, see Guideline 1C16.H. We want to also code all clinically significant conditions. All clinically significant conditions noted on routine newborn examinations should be coded. A condition is clinically significant if it requires one of the following: clinical evaluation or therapeutic treatment or diagnostic procedures or extended length of hospital stay or increased nursing care and or monitoring, or lastly, has implications for future health care needs. And just as a side note, the perinatal guidelines listed above are the same as the general coding guidelines for additional diagnoses, except for the final point regarding implications for future health care needs. Codes should be assigned for the conditions that have been specified by the provider as having implications for future healthcare needs. Okay, so next up we have observation and evaluation of newborns for suspected conditions not found. Number one, use of Z05 codes. Assign a code from category Z05 for observation and evaluation of a newborn for suspected diseases and conditions ruled out to identify those instances when a healthy newborn is evaluated for a suspected condition or disease that is determined after the study not to be present. Do not use a code from category Z05 when the patient is documented to have signs or symptoms of a suspected problem. In such cases, code the sign or symptom. Number two, Z05 on other than the birth record. A code from category Z05 may also be assigned as a principal or first listed code for readmissions or encounters when the code from category Z38 code no longer applies. Codes from category Z05 are for use only for healthy newborns and infants for which no condition after the study is found to be present. And number three for this section, Z05 on a birth record. A code from category Z05 is to be used as a secondary code after the code from category Z38 for live-born infants according to the place of birth and type of delivery. Next, we have coding additional perinatal diagnoses. Number one, assigning codes for conditions that require treatment. Assigning codes for conditions that require treatment or further investigation, prolong the length of stay, or require resource utilization. Number two, codes for conditions specified as having implications for future healthcare needs. Assign codes for conditions that have been specified by the provider as having implications for future healthcare needs. As a side note, this guideline should not be used for adult patients. Now, prematurity and fetal growth retardation. Providers utilize different criteria in determining prematurity. A code for prematurity should not be assigned unless it is documented. Assignment of codes in category P05 for disorders of newborn related to slow fetal growth and fetal malnutrition, and P07 for disorders of newborn related to short gestation and low birth weight, not elsewhere classified, should be based on the recorded birth weight and estimated gestational age. When both birth weight and gestational age are available, two codes from category P07 should be assigned with the code for birth weight sequenced before the code for gestational age. For low birth weight and immaturity status, codes from category P07 for disorders of newborn related to short gestation and low birth weight, not elsewhere classified, are for use for a child or adult who was premature or had a low birth weight as a newborn, and this is affecting the patient's current health status. For more information on this, see section 1C21 for factors influencing health status and contact with health services status. For bacterial sepsis of a newborn, category P36 for bacterial sepsis of newborn includes congenital sepsis. If a perinate is documented as having sepsis without documentation of congenital or community acquired, the default is congenital and a code from category P36 should be assigned. If the P36 code includes the causal organism, an additional code from category B95 for Streptococcus, Staphylococcus, and Enterococcus as the cause of diseases classified elsewhere, or B96 for other bacterial agents as the cause of diseases classified elsewhere, should not be assigned. If the P36 code does not include the causal organism, assign an additional code from category B96. If applicable, use additional codes to identify severe sepsis from subcategory R65.2 and any associated acute organ dysfunction. For stillbirth, code P95, stillbirth is only for use in institutions that maintain separate records for stillbirths. No other code should be used with P95. Code P95 should not be used on the mother's record. And lastly, for this page and for this chapter, COVID-19 infection in newborn. For a newborn that tests positive for COVID-19, assign code U07.1 for the COVID-19 and the appropriate codes for the associated manifestation or manifestations in neonates, newborns, in the absence of documentation indicating a specific type of transmission. For a newborn that tests positive for COVID-19 and the provider documents that the condition was contracted in utero during the birth process, assign codes P35.8 for other congenital viral diseases and U07.1 for the COVID-19. When coding the birth episode in a newborn record, the appropriate code from category Z38 for live-born infants according to place of birth and type of delivery should be assigned as the principal diagnosis. Next, we have Chapter 17. This is for congenital malformations, deformations, and chromosomal abnormalities for codes Q00 through QA1. Assign an appropriate code or codes from category Q00 through QA1 for congenital malformations, deformations, and chromosomal abnormalities when a malformation or deformation or chromosomal abnormality is documented. A malformation, deformation, or chromosomal abnormality may be the principal or first listed diagnosis on a record or a secondary diagnosis. When a malformation, deformation, or chromosomal abnormality does not have a unique code assignment, assign additional code or codes for any manifestations that may be present. When the code assignment specifically identifies the malformation, deformation, or chromosomal abnormality, manifestations that are an inherent component of the anomaly should not be coded separately. Additional codes should be assigned for the manifestations that are not an inherent component. Codes from Chapter 17 may be used throughout the life of the patient. If a congenital malformation or deformity has been corrected, a personal history code should be used to identify the history of the malformation or deformity. Although present at birth, a malformation, deformation, or chromosomal abnormality may not be identified till later in life. Whenever the condition is diagnosed by the provider, it is appropriate to assign the code from the code from codes Q00 through QA1. For the birth admission, the appropriate code from category Z38 for live-born infants according to place of birth and type of birth should be sequenced as the principal diagnosis, followed by any congenital anomalies from Q00 through QA1. That's going to finish us up for chapter 17. Now, for chapter 18, this is for signs, symptoms, and abnormal clinical and laboratory findings not elsewhere classified. And these codes are R00 through R99. Chapter 18 includes symptoms, signs, abnormal results of clinical or other investigative procedures, and ill-defined conditions regarding which no diagnosis classifiable elsewhere is recorded. Signs and symptoms that point to a specific diagnosis have been assigned to a category in other chapters of the classification. For use of symptom codes, codes that describe symptoms and signs are acceptable for reporting purposes when a related definitive diagnosis has not been established or confirmed by the provider. Use of a symptom code with a definitive diagnosis code. Codes for signs and symptoms may be reported in addition to a related definitive diagnosis when the sign or symptom is not routinely associated with that diagnosis, such as various signs and symptoms associated with complex syndromes. The definitive diagnosis code should be sequenced before the symptom code. Signs or symptoms that are associated with routinely with a disease process should not be assigned as an additional code unless otherwise instructed by the classification. When we talk about combination codes that include symptoms, ICD-10-CM contains a number of combination codes that identify both the definitive diagnosis and common symptoms of that diagnosis. When using one of these combination codes, an additional code should not be assigned for the symptom. With repeated falls, code R29.6, repeated falls, is for use for encounters when a patient has recently fallen and the reason for the fall is being investigated. Code Z91.81, history of falling, is for use when a patient has fallen in the past and is at risk for future falls. When appropriate, both codes R29.6 and Z91.81 may be assigned together. Coma. Code R40.20 for unspecified coma should be assigned when the underlying cause of the coma is not known or the cause is a traumatic brain injury and the coma scale is not documented in the medical record. Do not report codes for unspecified coma, individual or total Glasgow coma scale scores for a patient with a medically induced coma or a sedated patient. So now let's talk a little bit more about the coma scale. The coma scale codes are R40.21 to R40.24 that can be used in conjunction with traumatic brain injury codes. These codes cannot be used with a code R40.2A for non-traumatic coma due to an underlying condition. They are primarily used for trauma registries, but they may be used in any setting where this information is collected. The coma scale codes should be sequenced after the diagnosis code or codes. These codes, one from each subcategory, are needed to complete the scale. The seventh character indicates when the scale was recorded, and the seventh character should match for all three codes. At a minimum, report the initial score documented on presentation at your facility. This may be a score from the emergency medicine technician or EMT or in the emergency department. If desired, a facility may choose to capture multiple coma scale scores. Assign code R40.24 for Glasgow Coma Scale total score when the only total score is documented in the medical record and not the individual scores. If multiple coma scores are captured within the first 24 hours after hospital admission, assign only the code for the score at the time of admission. ICD-10 CM does not classify coma scores that are reported after admission but less than 24 hours later. For more information on this, you can see section 1B.14 for coma scale documentation by clinicians other than the patient's provider. The guideline for functional quadriplegia has been deleted effective October 1st, 2017. Next, for SIRS due to non-infectious process. If you want more complete information on SIRS, there are other areas of the ICD-10 chapter guidelines that we have previously covered. So please make sure that you check out our previous videos on the ICD-10 guidelines in relation to SIRS. But for this specific chapter, we're talking about signs and symptoms as it relates to SIRS. The systemic inflammatory response syndrome, or SIRS, can develop as a result of certain non-infectious disease processes such as trauma, malignant neoplasm, or pancreatitis. When SIRS is documented with a non-infectious condition and no subsequent infection is documented, the code for the underlying condition, such as an injury, should be assigned, followed by code R65.10 for systemic inflammatory response syndrome, or SIRS, of non-infectious origin without acute organ dysfunction, or code R65.11 for systemic inflammatory response syndrome of non-infectious origin with acute organ dysfunction. If an associated acute organ dysfunction is documented, the appropriate code or codes for the specific type of organ dysfunction or dysfunctions should be assigned in addition to code R65.11. If acute organ dysfunction is documented, but it cannot be determined if the acute organ dysfunction is associated with SIRS or due to another condition, for example, directly due to trauma, the provider should be queried. For death, NOS, or not otherwise specified, code R99, ill-defined and unknown cause of mortality, is only for use in the very limited circumstance when a patient who has already died is brought into an emergency room or other healthcare facility and is pronounced dead upon arrival. It does not represent the discharge disposition of death. And lastly, for this slide, the NIHSS stroke scale. The NIH stroke scale, codes R29.7, can be used in conjunction with acute stroke codes I60 through I63 to identify the patient's neurological status and the severity of the stroke. The stroke scale codes should be sequenced after the acute stroke diagnosis code or codes. At a minimum, report the initial score documented. If desired, a facility may choose to capture multiple stroke scale scores. For more information on this, see section IB14 for NIHSS stroke scale documentation by clinicians other than the patient's provider. Next, we have chapter 19. This is our last chapter for today's presentation. This is on injury, poisoning, and certain other consequences of external causes, codes S00 through T88. Okay, so first up, we have application of the seventh characters in chapter 19. Most categories in Chapter 19 have a seventh character requirement for each applicable code. Most categories in this chapter have 3 seventh character values, with the exception of fractures. A is for the initial encounter, D is for the subsequent encounter, and S is for sequela. Categories for traumatic fractures have additional seventh character values. While the patient may be seen for a new or different provider over the course of treatment for an injury, assignment of the seventh character is based on whether the patient is undergoing active treatment and not whether the provider is seeing the patient for the first time. For complication codes, active treatment refers to treatment for the condition described by the code, even though it may be related to an earlier precipitating problem. For example, code T84.50XA. Infection and inflammatory reaction due to unspecified internal joint prosthesis. Initial encounter is used when active treatment is being provided to the infection, even though the condition relates to a prosthetic device, implant, or graft that was placed at a previous encounter. Seventh character A, initial encounter, is used for each encounter where the patient is receiving active treatment for the condition. Seventh character D, subsequent encounter, is used for encounters after the patient has completed active treatment of the condition and is receiving routine care for the condition during the healing or recovery phase. The aftercare Z codes should not be used for aftercare for conditions such as injuries or poisonings, where seventh characters are provided to identify subsequent care. For example, for aftercare of an injury, assign the acute injury code with the seventh character D for subsequent encounter. Seventh character S for sequela is for use of complications or conditions that arise as a direct result of a condition, such as a scar formation after a burn. The scars are for sequelae of the burn. When using seventh character S, it is necessary to use both the injury code that precipitated the sequela and the code for the sequela itself. The S is added only to the injury code, not the sequela code. The seventh character S identifies the injury responsible for the sequela. The specific type of sequela, for example, scar, is sequenced first, followed by the injury code. For additional information on this, see section 1B10 for sequelae late effects. For coding of injuries, when coding injuries, assign separate codes for each injury unless a combination code is provided, in which the case combination code is assigned. Codes for category T07, unspecified multiple injuries, should not be assigned if the inpatient setting, unless information for more specific code is not available. Traumatic injury codes S00 through T14-9 are not to be used for normal healing surgical wounds or to identify complications of surgical wounds. The code for the most serious injury, as determined by the provider and the focus of treatment, is sequenced first. So, number one, for superficial injuries. Superficial injuries such as abrasions or contusions are not coded when associated with more severe injuries of the same site. Number two, primary injury with damage to nerves or blood vessels. When a primary injury results in a minor damage to the peripheral nerves or blood vessels, the primary injury is sequenced first with additional code or codes for the injuries to the nerves and spinal cord, such as category S04 and or injury to blood vessels such as category S15. When the primary injury is to the blood vessels or nerves, that the injury should be sequenced first. And lastly, on this screen, number three, iatrogenic injuries. Injury codes from Chapter 19 should not be assigned for injuries that occur during or as a result of a medical intervention. Assign the appropriate complication code or codes instead. Coding for traumatic fractures. The principles of multiple coding of injuries should be followed in coding fractures. Fractures of specified sites are coded individually by site in accordance with both the provisions within categories S02, S12, S22, S32, S42, S49, S52, 59, 62, 72, 79, 82, 89, and S92, and the level of detail furnished by the medical record content. A fracture not indicated as open or closed should be coded as closed by default. A fracture not indicated whether displaced or non-displaced should be coded as displaced as a default. More specific guidelines are as follows. Number one, initial versus subsequent encounter for fractures. Traumatic fractures are coded using the appropriate seventh character for initial encounter A, B, or C for each encounter where the patient is receiving active treatment for a fracture. The appropriate seventh character for initial encounter should also be assigned for a patient who delayed seeking medical treatment for the fracture or non-union. Fractures are coded using the appropriate seventh character for subsequent care for encounters after the patient has completed active treatment of the fracture and is receiving routine care of the fracture during the healing or recovery phase. Care for complications of surgical treatment for fracture repairs during the healing or recovery phase should be coded with the appropriate complication codes. Care of complications of fractures such as malunion and non-union should be reported with the appropriate seventh character for subsequent care with non-union, K, M, and N, or subsequent care with malunion, P, Q, or R. Malunion or non-union. The appropriate seventh character for the initial encounter should also be assigned for a patient who delayed seeking treatment for the fracture or non-union. The open fracture designations in the assignment of the seventh character for fractures of the forearm, femur, and lower leg, including ankle, are based on the Gustio open fracture classification. When the Gustio classification type is not specified for an open fracture, the seventh character for open fracture type 1 or 2 should be assigned with B, E, H, M, or Q. A code from category M80, not a traumatic fracture code, should be used for any patient with known osteoporosis who suffers a fracture, even if the patient had a minor fall or trauma, if that fall or trauma would not usually break a normal healthy bone. Again, this was covered in our last video, so please make sure to check that out if you haven't already. For more information, see section IC13 for osteoporosis. The aftercare Z codes should not be used for aftercare for traumatic fractures. For aftercare of a traumatic fracture, assign the acute fracture code with the appropriate 7th character. For multiple fracture sequencing, multiple fractures are sequenced in accordance with the severity of the fracture. Number 3, physeal fractures. Physeal fractures assign only the code identifying the type of physeal fracture. Do not assign a separate code to identify the specific bone that is fractured. And last for this slide, coding of burns and corrosions. The ICD-10-CM makes a distinction between burns and corrosions. The burn codes are for thermal burns, except sunburns, that come from a heat source such as a fire or hot appliance. The burn codes are also for burns resulting from electricity and radiation. Corrosions are burns due to chemicals. The guidelines are the same for burns and corrosions. Current burns T20 through T25 are classified by depth, extent, and by agent, or the X code. Burns are classified by the depth as first degree erythema, second degree blistering, and third degree full thickness involvement. Burns of the eye and internal organs T26 through T28 are classified by site, not by degree. Okay, so we have several guidelines we need to follow for the next section. Sequencing of burn and related condition codes. Sequence first the code that reflects the highest degree of burn when more than one burn is present. When the reason for the admission or encounter is for treatment of external multiple burns, sequence first the code that reflects the burn of the highest degree. When a patient has both internal and external burns, the circumstances of admission govern the selection of the principal diagnosis or first listed diagnosis. When a patient is admitted for burn injuries and other related conditions such as smoke inhalation and or respiratory failure, the circumstances of admission govern the selection of the principal or first listed diagnosis. Number 2, burns of the same anatomic site. Classify burns of the same anatomic site and on the same side but different degrees to the subcategory identifying the highest degree recorded in the diagnosis. For example, for second and third degree burns of the right thigh, assign only code T24.311. Number 3, non-healing burns. Non-healing burns are coded as acute burns. Necrosis of burned skin should be coded as a non-healed burn. Number 4, an infected burn. For any documented infected burn site, use an additional code for the infection. Assign separate codes for each burn site. When coding burns, assign a separate code for each burn site. Category T30, burn and corrosion, body region, unspecified, is extremely vague and should be used rarely. Okay, rarely use that when only you have no way to query your provider. Codes for burns of multiple sites should only be assigned when the medical record documentation does not specify the individual sites. For burns and corrosions classified according to extent of body surface involved. Assign codes from category T31 for burns classified according to the extent of body surface involved, or T32 corrosions classified according to extent of body surface involved for acute burns or corrosions when the site of the burn or corrosion is not specified or when there is a need for additional data. It is advisable to use category T31 as additional coding when needed to provide data for evaluating burn mortality, such as that needed for burn units. It is also advisable to use category T31 as an additional code for reporting purposes when there is mention of a third-degree burn involving 20% or more of the body surface. Codes from category T31 and T32 should not be used for sequelae of burns or corrosions. Categories T31 and T32 are based on the classic rule of nines. In estimating body surface involved, head and neck are assigned 9%. Each arm is 9%. Each leg, 18%. The anterior trunk, 18%, posterior trunk, 18%, and genitalia, 1%. Providers may change these percentage assignments where necessary to accommodate infants and children who have proportionately larger heads than adults and patients who have large buttocks, thighs, or abdomen that involve burns. Encounters for treatment of sequelae of burns. Encounters for the treatment of late effects of burns or corrosions, for example, scars or joint contractures, should be coded with a burn or corrosion code with the 7th character S for sequela. Sequelae with a late effect code and current burn. When appropriate, both a code for the current burn or corrosion with the 7th character A or D and a burn or corrosion code with 7th character S may be assigned on the same record when both a current burn and a sequelae of an old burn exist. Burns and corrosions do not heal at the same rate, and a current healing wound may still exist with a sequela of a healed burn or corrosion. For additional information, see section IB10, sequela or late effects. Lastly, for this slide, use of an external cause code with burns and corrosions. An external cause code should be used with burns and corrosions to identify the source and intent of the burn, as well as the place where it occurred. Adverse effects, poisoning, underdosing, and toxic effects. Codes in categories T36 through T65 are combination codes that include the substance that was taken as well as the intent. No additional external cause code is required for poisoning, toxic effects, adverse effects, and underdosing codes. Number 1, do not code directly from the table of drugs. Do not code directly from the table of drugs and chemicals. Always referred back to the tabular list. Number 2, use as many codes as necessary to describe completely all drugs, medicinal, or biological substances. Number 3, if the same code would describe the causative agent for more than one adverse reaction, poisoning, toxic effect, or underdosing, assign the code only once. Number 4, if 2 or more drugs, medicinal, or biological substances are taken, code each individually unless a combination code is listed in the table of drugs and chemicals. If multiple unspecified drugs, medicinal, or biological substances were taken, assign the appropriate code from subcategory T50.91. Poisoning by adverse effect of and underdosing of multiple unspecified drugs, medicaments, and biological substances. The occurrence of drug toxicity is classified by ICD-10 as follows. Adverse effect. When coding an adverse effect of a drug that has been correctly prescribed and properly administered, assign the appropriate code for the nature of the adverse effect, followed by the appropriate code for the adverse effect of the drug, category T36 through T50. The code for the drug should have a fifth or sixth character of 5. For example, T36.0x5. Examples of the nature and adverse effect are tachycardia, delirium, gastrointestinal hemorrhaging, vomiting, hypokalemia, hepatitis, renal failure, or respiratory failure. B. Poisoning. When coding a poisoning or reaction to the improper use of a medication, such as overdose, wrong substance given or taken in error, or wrong route of administration. First, assign the appropriate code from categories T36 through T50. The poisoning codes have associated intent as their fifth or sixth character, such as accidental, intentional self-harm, assault, and undetermined. If the intent of the poisoning is unknown or unspecified, code the intent as accidental intent. The undetermined intent is only for use if the documentation in the record specifies the intent cannot be determined. Use additional code or codes for all manifestations of poisonings. If there is also a diagnosis of abuse or dependence of a substance, the abuse or dependence is assigned as an additional code. Examples of poisonings include error was made in drug prescription. Errors made in drug prescription or in the administration of a drug by the provider, nurse, patient, or other person. Overdose of a drug intentionally taken. If an overdose of a drug was intentionally taken or administered and resulted in drug toxicity, it would be coded as a poisoning. Non-prescribed drug taken with correctly prescribed and properly administering drug. If a non-prescribed drug or medicinal agent was taken in combination with a correctly prescribed and properly administered drug, any drug toxicity or other reaction resulting from the interaction of the two drugs would be classified as poisoning. With an interaction of drug or drugs and alcohol, when a reaction results from the interaction of a drug or drugs with alcohol, this would be classified as a poisoning. For additional information, see section 1C4 if poisoning is a result of insulin pump malfunctions. For sequela or late effects, see section 1B10. Underdosing. Underdosing refers to taking less of a medication than prescribed by a provider or a manufacturer's instruction. Discontinuing the use of a prescribed medication on the patient's own initiative, as is not directed by the patient's provider, it is also classified as underdosing. For underdosing, assign the code from categories T36 through T50 with a fifth or sixth character 6. Documentation of a change in the patient's condition is not required in order to assign an underdosing code. Documentation that the patient is taking less of a medication than is prescribed or discontinued the prescription medication is sufficient for code assignment. Codes for underdosing should never be assigned as principal or first listed codes. If a patient has a relapse or exacerbation of a medical condition for which the drug is prescribed because of the reduction in dose, then the medical condition itself should be coded. Noncompliance codes Z91 Z91.12, Z91.13, Z91.14, and Z91.A4, or complication of care codes Y63.6 through Y63.9. Codes are to be used with an underdosing code to indicate intent if known. For toxic effects, when a harmful substance is ingested or comes in contact with a person, that is classified as a toxic effect. The toxic effect codes are in categories T51 through T65. When coding toxic effect, assign the toxic effect code first, followed by codes for all associated manifestations of the toxic effect. Toxic effect codes have an associated intent: accidental, intentional self-harm, assault, and undetermined. For sequela or late effects, see section 1B10 for sequela. Adult and child abuse, neglect, and other maltreatment. Sequence first the appropriate code from categories T74 for adult and child abuse, neglect, and other maltreatment. Confirmed or T76 adult and child abuse, neglect, and other maltreatment suspected for abuse, neglect, and other maltreatment, followed by any accompanying mental health or injury code or codes. If the documentation in the medical record states abuse or neglect, it is coded as confirmed T74. It is coded as suspected if the documentation or if it's documented as suspected T76. For cases of confirmed abuse or neglect as external cause code from the assault section, X92 through Y09 should be added to identify the cause of any physical injuries. A perpetrator code Y07 should be added when the perpetrator of the abuse is known. For suspected cases of abuse or neglect, do not report an external cause code or a perpetrator code. If a suspected case of abuse, neglect, or mistreatment is ruled out during an encounter, code Z0471 for encounter for examination and observation following alleged physical adult abuse ruled out, or Z0472 encounter for examination and observation following alleged child abuse ruled out, should be used, not a code from T76. If a suspected case of alleged rape or sexual abuse is ruled out during an encounter, use code Z04.41. Excuse me. Yes, 41. Encounter for examination and observation following alleged rape, code Z0442. Encounter for examination and observation following alleged child rape should be used, not code from category T76. If a suspected case of forced sexual exploitation or forced labor exploitation is ruled out during an encounter, use code Z0481. Encounter for examination and observation of a victim forced sexual exploitation, or code Z0482. Encounter for examination and observation of a victim following forced labor exploitation should be used, not a code from T76. If you want additional information on this, see section 1C15 for abuse in a pregnant patient. And last up, we have general guidelines for complications of care. Number 1, documentation of complications of care. If you want additional information on this, see section 1B16 for information on documentation of complications of care. For pain due to medical devices, pain associated with devices, implants, or grafts left in a surgical site, for example, painful hip prosthesis, is assigned to the appropriate code or codes found in Chapter 19, Injury, Poisoning, and Certain Other Consequences of External Causes. Specific codes for pain due to medical devices are found in the T code section of the ICD-10 CM. Use additional code or codes from category G89 to identify acute or chronic pain due to the presence of a device, implant, or graft. G codes G89.18 or G89.28, both of which we covered in a previous session. And lastly, on this page, we have transplant complications. Transplant complications other than kidney. Codes under category T86 for complications of transplanted organs and tissues are for use for both complications and rejection of transplanted organs. A transplant complication code is only assigned if the complication affects the function of the transplanted organ. Two codes are required to fully describe a transplanted complication: the appropriate code from category T86 and a secondary code that identifies the complication. Pre-existing conditions or conditions that develop after the transplant are not coded as complications unless they affect the function of the transplanted organs. For additional information, see 1C21 for transplanted organ removal status, IC2 for malignant neoplasm associated with transplanted organ, or IC.1D4 for sequencing of sepsis due to an infection in the transplanted organ. Kidney transplant complications. A patient who has undergone kidney transplant may still have some form of chronic kidney disease. Because the kidney transplant may not fully restore kidney function, code T86.1 should be assigned for documented complications of a kidney transplant, such as transplant failure or rejection or other transplant complication. Code T86.1 should not be assigned for post-kidney transplant patients who have chronic kidney disease unless a transplant complication such as transplant failure or rejection is documented. If the documentation is unclear as to whether the patient has a complication of the transplant, make sure you query your provider. Conditions that affect the function of the transplanted kidney other than CKD should be assigned a code from subcategory T86.1 for complications of transplanted organ, kidney, and a secondary code that identifies the complication. For patients with CKD following a kidney transplant, but who do not have a complication such as failure or rejection, see section IC14 for CKD and kidney transplant status, or IC1D4 for sequencing of sepsis due to infection in a transplanted organ. Number 4, complication codes that include the external cause. As with certain other T codes, some of the complications of care codes have the external cause included in the code. The code includes the nature of the complication as well as the type of procedure that caused the complication. No external cause code indicating the type of procedure is necessary for these codes. And lastly, for today's presentation, number 5, complications of care codes within the body system chapters. Intraoperative and post-procedural complication codes are found within the body system chapters with codes specific to the organs and structures of that body system. These codes should be sequenced first, followed by a code or codes for the specific complication if applicable. Complication codes from the body system chapters should be assigned for intraoperative and post-procedural complications. For example, the appropriate complication code from Chapter 9 would be assigned for a vascular, intraoperative, or post-procedural complication unless the complication is specifically indexed to a T code in Chapter 19. So that's going to close us out for today's presentation. I hope you enjoyed today's session. Please make sure that you subscribe to the channel, go and give us a like on Facebook, and follow us over on LinkedIn. If you would like more sessions like this, feel free to leave us a review or reach out to us directly if you have things that you would like us to do presentations on. The only resource for today's presentation is the ICD-10 CM Fiscal Year 2026 Guidelines. I hope you all have a great day and look forward to seeing you on another episode.